si tu as toujours été dans la même terre.
Good morning. My name is Michelle Morse.
And I'm Mike Westerhouse.
And we would like to welcome you to Reimagining Social Medicine. We are so grateful that you're all here with us today on a Saturday morning. And we're very excited for the speakers that we have who've been making lots of sacrifices to be with us. Mike and I would like to just start by sharing a personal connection that we feel we both have to this movement around social medicine. I would just like to briefly share an experience that happened last week, actually. I was in New Orleans with several colleagues, and we went to visit the Whitney Plantation in Wallace, Louisiana. And the Whitney Plantation is unfortunately the only plantation in the continental U.S. that is focused on the actual experience of slaves and how their experience as slaves is documented. And my colleagues and I came upon this statue, which is called Field of Angels. And the statue represents a mother with a child and is dedicated to 2,200 children who were slaves that died in this region of the country between 1823 and 1864. And we all began reflecting on the ripple effects of slavery in modern day America and around the world. And one of the things that brought this home for me was that on the wall that you see behind this statue, there were several other walls with thousands and thousands of names. And we all had a chance to look at the names and reflect on the lives of the slaves and children that died. And I saw my name on that wall. The name Michelle was written multiple times. And it made me feel personally very connected, again, with the history of slavery and my ancestors as a Black American, and also made me think about the diaspora. And many of the people here today represent the diaspora, as well as many Africans from all around the world. And how does that connect to health disparities today in both America and around the world? And how, as Black Americans, can we both reflect on our history of slavery, as well as connect with Africans all over the continent who are still suffering from unbelievable poverty and untimely death? And how can we be more fully human by connecting with that experience, inequity, and actually working together to change it?
My personal story goes back to April 2010, when I was a resident in global health equity. And I was working at a rural community health center in northern Uganda, a very remote region. And on April 20th, went out with a group to do a very routine community health vaccination. I was with a clinic staff at the center, some folks from a foreign NGO, and a great team of community health workers. And that day, this was a very routine thing, but something happened that I hadn't necessarily always been paying attention to. And that was when we got back to the clinic, where we were all staying at the end of the day, we were all called forward for our lunch money. And I went up to got my lunch money, and I was given 20,000 Ugandan shillings, which at the time was about $10. And as I was signing my name, I noticed all the other names below it were getting 5,000 Ugandan shillings, so quite a bit less than I was being given. And I really had been mainly an observer there that day. The community health workers are being given quite a bit less. The clinic staff who had planned the event that day and the outing, the NGO workers were all being given quite a bit less money. And it made me recognize that even in global health, there are a lot of hidden privileges that often we aren't always paying attention to. And it got me thinking that things like structural violence, racism, white privilege, inequities are all things within which we are deeply enmeshed, even when we're working in fields that are sort of professed to be working against them. And from that point forward, this has felt like much more of sort of a personal, self-aware, reflective component to working in global health and working for health equities. So it's these kinds of personal stories paired together with sort of a broader, deep dissatisfaction with some of the things that are missing in traditional medical and health professional education around paying attention to some of these gritty realities, paying attention to these social determinants that really gave rise to the Social Medicine Consortium, which has grown now to be a group of individuals, organizations, universities who are really committed to sitting down and thinking about how can we drive a transformation in health professional education that more fully embraces social medicine as a core component of the training. And that's part of what we're here to do today and learn about and hear from a great group of people. We want to thank a lot of people who have gone into helping make this happen today. These are folks who heard our ideas and said, yeah, that sounds like it's worthy of a gathering. And they also got the idea that we had felt it was really important to include in the conversation voices from people who are often excluded from these conversations. So our partners from all over the world who are here with us today and we'll have the opportunity to hear from. To name just some of the sponsors who have been very involved, these folks are the Macy Foundation, the University of Minnesota Department of Medicine, the Global Health Pathway, Health Partners, WellShare International. Also here at the University of Minnesota, the African Studies Initiative, the Center for Bioethics and the Department of Anthropology, the University of St. Thomas, Brigham and Women's Hospital and the organization Partners in Health, St. Joan of Arc Catholic Community, and the Minnesota Public Health Association. We're deeply grateful for their support today.
We're very lucky that today isn't isolated. And as we mentioned, over the past 2 days, we've had this gathering of over 65 health professionals from all over the world. And over 80% of the people who participated in this conference said that they came for these 2 days in Minneapolis to actually be a part of a growing social movement towards pushing for social medicine education and its integration into medical education. Over the past 2 days, these health professionals have been having very, very challenging conversations about how we can actually fight the status quo and change it, and how we can actually change the conversation about health equity in this world. 25 of these leaders are from Uganda, Haiti, Rwanda, Zimbabwe, and El Salvador. We have over 100 remote attendees participating in the conference today, who are on video with us, and they represent 35 different countries, so we hope they're listening. And we'd like to thank Jeff and Rita, who are from Life Image and who have graciously helped to make it possible for those 100 health professionals from 35 countries to participate remotely with us today. And now I'd like to introduce you to 3 of those many fantastic health professionals from around the world who are going to be guiding us throughout the day today as our MCs. Tinashe Garonga, who's a medical student from Zimbabwe, Angela Namwase, who's a nursing student from Uganda, and Stacy Middy, who's a 4th-year medical student from Haiti.
Good morning. It's so great to have you here, and looking forward to having a lot of energy in the room. So we're going to be your MCs for the day. My name is Angela, and I'm from Uganda. Throughout the day, we shall be talking about the 3 Ps that we connect with social medicine, and one of them will be personal, just like the previous speakers have shared their personal stories. We all have a personal connection to social medicine, and looking forward to connecting with you.
Okay, I'm Tinashe Garonga, and I'm from Zimbabwe. And one of the most important P's for the day is going to be partnership. Partnership shows the interrelationship between personal when you're talking about working together as equals, constantly reflecting in constructive dialogue, so in order to come up with action.
Another P will be praxis. A good way to think about praxis will be action. It's noun and verb, where the verb's taking action on the noun. For example, inequity kills and poverty limit. Now we are having Tinashe for introducing us to our next speaker.
Yes, thank you very much. So I have the honor to introduce the first speaker of the day. The first speaker of the day is Dr. Edward Ehlinger. He's the Health Commissioner of Minnesota, very passionate about health equity, social justice, and the structural issues involved. And he's going to present on the inequalities in Minnesota and around the world. Then he's also going to talk about the structural issues related in his topic, why social medicine, health inequity, structural factors, and the triple M of health equity. Let's put our hands together for Dr. Edward Ehlinger.
Good morning, everyone. It's great to see this crowd, the energy that's here, the excitement. I know the governor, who's really been focusing on advancing equity, would really be pleased with this because this shows that there are many people who are really supportive of this effort. It's really nice to be here with you. It's nice to be here on this smoke-free campus that I worked for many years to get to be smoke-free. And it's nice to be on the stage. I wish I could do a pirouette or a jeté or something. This is where the dance all occurs. And you're going to be hearing lots of stories. We were told that we should really tell this in terms of a story, and you're going to be hearing stories with a lot of international focus. My story is going to be very domestic, and you'll see that it comes from starting that once upon a time. There was this little boy growing up in Green Bay, Wisconsin, and in 1953, at 7 years old, went with his father to the Green Bay Packer football game. That's when the stadium was not Lambeau Field, but it was about 6 or 7 blocks from my house. And got to go with my dad, and at that time, I was able to sit actually on the field, in the end zone, and watch the players. And one of the things that was there that I saw was the program that said Howie Ferguson is the only person in the whole agenda, whole lineup, that had no college when it said, sort of the demographics. And so when I asked my dad about no college. Everybody else has college. He said, it's a sign. Education is really important. If you don't have a good education, you're not going to be as successful as you should be and could be in this world. So think about education. And so age 7, I decided, I guess I better go to college. The other thing is I walked around the stands and I walked past the Packer bench, and there was Bobby Mann. Someone who didn't look at all like anybody I'd ever seen before. He was the first African American I ever saw. And so on my way home from the football game, I asked my dad, tell me about this man. I've never seen anybody like him. He said, well, he can only come into Green Bay during the football season, has to leave at the end of the season. And I said, well, why don't I see him downtown? He has to live on the outskirts of town. I said, well, that doesn't seem fair. And my dad said, that's right. It's not fair. It's not right. But maybe your generation can help change that. So it was sort of the thought at that point in time, science is important, medicine is important, social justice is important. 10 years later, 1963, junior in high school, I read this book, The Other America by Michael Harrington. It said there's a familiar America that all of us know, but in it there are tens of millions who are living in circumstances that don't really adequately improve their health. They were without adequate housing, education, and medical care. It was then that I decided, medicine would be a good place to go to really address some of those inequities. 10 years later, 1973, I'm in the National Health Service Corps, doing what I thought I would always be doing, working in a rural community as a GP. And it didn't take me very long before seeing 30 patients a day, realizing that I could be doing this for the rest of my life. And yes, I'd make a difference in the lives of these individuals who came to my office, but it really wouldn't change the health of that community. There are too many other factors that were interfering with their health. Tobacco use, violence, workplace injuries, obesity, all sorts of things. So it was then that I decided that I needed to look at another approach to medicine. And that's really when I became interested in public health. So I got my first job as the director of maternal and child health for the Minneapolis Health Department in 1980. And the issue that I was dealing with my MCH training from the University of North Carolina, Chapel Hill, was infant mortality. We did one of the first reports on disparities, black-white disparities in infant death rates in Minnesota. and looked at the data. So for the next 15 years working for the city of Minneapolis, I worked on increasing access to prenatal care, regional perinatal care coverage, improving newborn intensive care units, getting people enrolled in Medicaid, getting people enrolled in WIC, educating people about what they should do to take care of themselves. And then left and ran the health service here at the University of Minnesota for 16 years. And then in 2011, the last point on this slide, I was appointed by Governor Dayton to be health commissioner. So one of the first things I did was go back and look at what had happened about infant mortality in those intervening 31 years from when I started. And it shocked me that the black infant mortality rate in 2011 still had not reached the white infant mortality rate of 1980. 31 years, and we had not achieved anything close to equity in infant health. And that's when it really struck me that this definition of public health from Jeffrey Vickers is so important, that the landmarks of political, economic, and social history are the moments when some condition passed from the category of the given into the category of the intolerable. I believe that the history of public health might well be written as a record of successive redefinings of the unacceptable. To me, the infant mortality rates, the disparities that persisted for those 31 years were unacceptable. Yet it's a given in our country that African Americans and American Indians are going to have 2 to 2.5 times the infant mortality rates as white. It's just a given. It's just a given that African American males, teenage males, are going to be incarcerated 10 times more. And it's just a given that our healthcare system is going to perpetuate what it's always been doing. I think those are the intolerables that we have to pay attention to. We have to define them as unacceptable and change from the given to the unacceptable. But it's not just those individual statistics, it's affecting all of us. Our international ratings in infant mortality have been going down steadily over the last 30, 40 years. Our rank internationally has dropped dramatically. Similarly, our life expectancy hasn't been keeping up with the rest of the industrialized world. As you can see where the arrow is, the blue lines are male and female life expectancy at birth compared to the average of the OECD countries. And you can see right around 1980, we started to slow, we started to plateau. Why do you think that was? Well, the arrow that I have with the line going from the lower left to the upper right is the black-white disparity in infant mortality. Our rates of disparity in infant mortality, black-white differences, started to really increase in the late 70s and early 80s and have gone dramatically higher. Similarly, in life expectancy on the other end of the spectrum, black life expectancy started to plateau in 1980. And it was, I believe, it's those disparities that really impacted all of our health, because the data are showing that when everybody benefits, that places that have higher levels of inequity have overall lower levels of health. And I don't think it's coincidental that about the same time that our disparities started to increase, that our life expectancy started to decrease, and our ranking in infant mortality started to decrease, our costs started to increase. I think they're linked. And so why did this happen? What was behind this? I believe a lot of it has to do with the worldview that we have in this country. Our worldview that it's bootstraps individual. Pull yourself up by your bootstraps. The free market is going to solve all of the problems. The smaller the government, the better. Get government out of the way. Education is for job training. There's no structural discrimination. That's a thing of the past. Rely on technology. This is the worldview that we have that forms all of the policies and systems and programs that we have. And what that does is it really decreases our investment in the commons, the things that really make us all healthy, a thing that we all depend on. It increases polarization and decreases cooperation. It really focuses a lot on competition and our overinvestment because of this in the biomedical model, which you'll be hearing about later on, I'm sure. And it's not that the investment in the biomedical model, I think, is really instructive in that it's not our total investment in health, it's our investment in the biomedical piece. This is from the Institute of Medicine looking at total health and human services spending in industrialized countries. And you can see the United States there in the middle. Total health and human services dollars, we're right in the middle, probably where we should be. The difference is that we spend much more on medical care than any other country, both in terms of total dollars and percentage. For every dollar spent on healthcare in OECD countries, about $2 are spent on human services and social services. In the United States, for every dollar spent on medical care, only 55 cents are spent on social services. And we are recognizing that it's those social conditions, those social services, those human services and public health that really make the biggest impact on health. And so how have we responded to all of this with that biomedical model? Well, we said we've got to improve our healthcare system. So we had the triple aim of healthcare: better care for individuals, lower per capita costs, better health for populations. Well, I have to tell you from my perspective that the triple aim of healthcare actually has not moved us in the direction that we want. And actually by itself, the triple aim of healthcare is probably detrimental to health, because it takes an individual health model, not a community health model. It assumes that an individual can be healthy independent of his or her surroundings or his or her community. And what's good for healthcare is not necessarily what's good for community or advancing health equity. Hospitals and clinics invest in what they think is best for themselves. It makes them the benevolent dictator of health. Everything is viewed through the eyes of healthcare. And certainly in our conversations about health equity, the conversation keeps going back to healthcare, access to healthcare, improving healthcare. And we know, as you saw earlier, that it's much more than that. And it reinforces that narrative about what creates health. And certainly as my job as State Health Commissioner and as President of ASTO, I've got a bully pulpit like I've never had before. And I think my job is to actually help change the narrative, or at least try to change the narrative about what creates health. And the dominant narrative from the worldview that we have is that people would be healthy if they just worked hard, made good choices about diet, physical activity, and substance use, and had good medical care. Or being crass about it, health is the responsibility of the individuals until they get sick, and then it becomes the responsibility of the healthcare system. Well, as you saw in an earlier slide, it's much different than that. The real determinants of health are really the social and economic conditions that impact where we live and where we go to school and where we work. And certainly our physical environment, our social environment are really important. And so I believe that we really need to take a different look at what's going on. We need to really approach our healthcare system and our creation of health a little differently. So I look back at history, at some of the other stories. So we need to learn from the cholera epidemic 151 years ago, when cholera was plaguing London and the social conditions were impacting health and people were dying. We all know the story about John Snow and his epidemiological approach in taking off the pump handle. But he couldn't have done that without Reverend Henry Whitehead, who actually got him into the community and talked with the people and be able to find that index case. And actually, it wasn't the pump handle, it was Joseph Bazalgette who created the sewer system in London that actually made cholera controllable. That is one thing, 150 years ago. Then 100 years ago, 101 years ago, when social conditions were also being identified in this country, working conditions, the people came together with the Welch-Rose report that really helped create schools of public health. And one of the people at that time, who sometimes gets disparaged for creating the biomedical system that we have today that has not served us as well as we would like, but Abraham Flexner, I think in his heart, knew a lot more than what came out in the Flexner report. He said, "The physician's function is fast becoming social and preventive, rather than individual and curative. Don't forget that directly or indirectly, disease has been found to depend largely on an unpropitious environment. These are matters for social regulation, and doctors have the duty to promote social conditions that conduce to physical well-being." At the same time that they were pulling that together, CEA Winslow, who was the dean of the School of Public Health, had a definition of public health that some of the traditional things, prevent, prolong, promote, all of the things that we really hear about all the time. But he went on in his definition, we'd do sanitation, communicable disease control, education, organization of the medical and nursing services, but mostly the development of the social machinery to ensure everyone a standard of living adequate for the maintenance of health. So organizing these benefits to enable every citizen his birthright of health and longevity. So the medical community, the public health community recognized we needed to focus on the social conditions. That's what we were really focusing on. That's what they were trying to do back in 1910, 1915. And then 50 years later, 50 years ago, the War on Poverty, the 89th Congress, probably the most beneficial, most effective Congress ever. Head Start, Medicare, Medicaid, neighborhood health centers, food stamps, voting rights. They took a health and all policies approach. They took a community-oriented approach. They took a community engagement approach and had a broader definition of health and made huge progress in that. And so I think we need to learn from those historical pieces about what we can do here now in that 150, 150, and now today. There were some commonalities back in each of those and things that we have today, that there are some givens that need to become intolerable. There's a changing social, political, and economic environment that we have to pay attention to, we have to take advantage of. And we have to approach the conditions that create health, addressing the social, economic, and environmental factors, implement a health and all policies, multi-sector approach, and engage the community. That's why I've put together something called the triple aim of health equity, to balance off the triple aim of health care, which really focuses on expanding our understanding about what creates health, implementing a health and all policies approach with health equity as the goal, and strengthening the capacity of communities to create their own healthy future. All built around the idea of social cohesion, that we do all of this in relationship. We all would do this all in partnership. We're all doing this in terms of building social capital. And certainly in that expanding our understanding, we know that the community that you live in is really important to your health. The community itself impacts your health, but the community itself also impacts the choices that you have available to yourself. So I believe, I don't have any data to support this, but this is my view, that really behaviors are really, individual choice and behaviors are important, but they're relatively small. It's really the conditions that make the healthy choice sometimes not even the possible choice. So 60 to 80% really are socioeconomic factors. And those factors are really about the policies that are in place that support or undermine health. And we also need to look at this World Health Organization framework on social determinants. Going from the right, where you have the individual and health and equity and the material circumstances. This is where the medical care system really can have a big impact. And I believe that we are making some progress in terms of treating individuals in the context of their community. But if we're going to really have an impact, we're going to have to look at all of the factors that influence those material circumstances. This is where the broader understanding of health has to come in. We know that policies really impact education, occupation, and income, and they impact social class and gender and racism, which are really undermining many of the factors. And those are the policies where we have to change. But social medicine can really work on an individual level, in a community level, in a healthcare level, focusing on the determinants, the conditions in which people live, but also help to build the social capital. That's where I think clinicians really can help to build that social capital. And finally, supporting the capacity of communities to create their own healthy futures. We live in communities, all parts of this community. This is the social well-being that we have. And I think our healthcare system, our accountable care organizations, our healthcare homes, our community care teams have to be embedded in the community and change the governance structure so that healthcare and health is not the responsibility of the healthcare system, and health is not the responsibility of the public health system, but health is actually the responsibility of the community. So I think a lot of this is changing the governance that we have to make sure that investments are really made by the community. And I have lots of stories with that, but I don't have time to tell you. So I want to say what we're talking about today is not new ideas. Most of us who are physicians swore something like the Hippocratic Oath. I swear by Apollo the healer, Asclepius, the god of medicine, Hygeia, the goddess of public health, and Panacea, the goddess of well-being, sort of the social determinants of health. We swore by those medical care, public health, and social determinants of health to do what we can to improve health. Rudolf Virchow, really the father of social medicine, father of pathology, said, "Medical education does not exist to teach individuals how to make a living, but to empower them to protect the health of the public. Physicians are the natural attorneys of the poor, and the social problems should be largely solved by them." So we're going back to our roots. So this is what we've been trained for. This is why most of us went into healthcare. And finally, if we looked at life expectancy over the in the 20th century, you can see that we've made, 30 years. And it has been claimed that 25 of those 30 years were because of public health achievements. But we started to slow and in the latter half, when I think medicine and public health started to go apart, partly because of some of the work that was done in putting with Flexner report and those kinds of things. And I think we now recognize if we're going to deal with social determinants, we have to come back together again. And I believe that the progress that we made in the first part of the 20th century, because medicine and public health were working collectively. So I believe that the gains were not just due to public health, but I think most of the gains were because we took a health in all policies approach over those first 50 years. We approached the integration of medical care and public health, and we engaged communities in ways that we have not been doing recently. So I think we need to continue to improve health care with the triple aim of health care, really need to look at the conditions in which people live and treat individuals in the context of their community. But we also need to look at that broader framework of the World Health Organization and really adopt that triple aim of health equity, where we expand our understanding about what creates health. We support a health in all policies with health equity as a goal, and we strengthen the capacity of communities to create their own healthy future. Health is the responsibility of all of us. The definition that the Institute of Medicine has for public health is what we as a society do collectively to assure the conditions in which people can be healthy. All of us are public health workers. All of us have a responsibility to work collectively to assure the conditions. Healthcare is one of those conditions, but so is housing, economic development, criminal justice, education, all of those. And I think those of you in this audience and those of you who are on the video and everybody you meet has a role to play in that, and I'm convinced, seeing the energy in this room, that that's going to happen. Thank you very much.